Clinical diagnostics define primary sarcopenia as the age-related decline in skeletal muscle. Patients lose lean mass as they get older, yet tracking this tissue loss alone leaves a massive gap in the clinical picture. This dual-axis chart plots age against muscle metrics. The first line tracks muscle mass, showing a gradual decline after age 60. But the second line tracks muscle strength, revealing a sharply accelerated, much steeper trajectory. Older adults lose physical strength and power at a rate that vastly outpaces the loss of muscle size. Standard diagnostic heuristics look for shrinking tissue cross-sections. They quantify structural loss, but they fail to explain why the remaining tissue is unable to generate adequate force. Muscle aging involves an active pathology. An internal mechanism is destroying the limb's power output from within, independent of volume loss. The aging thigh undergoes a profound structural remodeling. This side-by-side cross-section compares a 25-year-old thigh with a 75-year-old thigh. While the aged muscle loses 18% of its total area, it simultaneously gains a stark accumulation of ectopic fat, marbling directly into the muscle architecture. This phenomenon is called myosteatosis. It is the abnormal accumulation of intermuscular adipose tissue, or IMAT, depositing lipids into spaces that are not anatomically designed to store them. IMAT behaves as a highly active, disruptive endocrine organ, influencing the surrounding environment. This transition suggests that sarcopenia is an infiltrative disease driven by ectopic fat rather than a simple subtractive condition. This bar chart visualizes longitudinal cohort data tracking baseline intermuscular fat. Over a tight 5-year period, we see a massive spike, a 35.5 to 74.6% increase in intermuscular fat among aging males. This aggressive expansion occurs even if the patient maintains a perfectly stable total body weight. Epigenetic and functional profiling shows that IMAT behaves similarly to visceral adipose tissue, the dangerous, metabolically active fat that surrounds internal organs. Once established, this localized fat continuously secretes pro-inflammatory cytokines, specifically interleukin-6. This saturates the adjacent muscle fibers in a state of chronic local inflammation. The rapid buildup of IMAT creates a toxic microenvironment that triggers a cascade of mechanical failures across the entire limb. This cross-section of a muscle fascicle shows the physical shift caused by that inflammatory stress. The large, explosive type 2X fast-twitch fibers undergo near-total eradication, leaving behind an overwhelming majority of the smaller, slower type 1 fibers. The damage extends to the neuromuscular junction. The physical wiring connecting the nervous system to the muscle begins to fail. The nerve's terminal branches fragment, and the acetylcholine vesicles required to transmit signals deplete. Clinicians track this denervation in real time. Patients experiencing this decay exhibit elevated levels of neurofilament light chain, or NFL, circulating in their blood. Myosteatosis actively dismantles the muscle's explosive power cells and short-circuits its neural wiring. If skeletal muscle is not anatomically designed to store large volumes of lipid, where are these ectopic adipocytes coming from? The answer lies in the microscopic interstitial spaces between the muscle fibers. This canyon-like area is a regenerative niche, populated by dormant progenitor cells. Two specific cell types operate here: fibroadipogenic progenitors, or FAPs, and skeletal muscle satellite cells. They form the tissue's vital repair machinery. In their healthy state, young FAP cells secrete follistatin. This perfectly orchestrates the satellite cells to activate, form new myotubes, and repair physical damage to the tissue. Healthy muscle possesses precise, built-in regenerative machinery. The massive accumulation of fat in older adults is a symptom of cellular betrayal, where this exact repair system breaks down. The aging process alters the surrounding biochemical environment, drastically elevating the presence of fibroblast growth factor 2, or FGF2. These molecules arrive and dock aggressively into the surface receptors of the FAP cells. This docking triggers a pathological internal cascade. It forces the activation of MEK1/2 and ERK1/2 pathways inside the cell. The internal signaling spike overloads the nucleus, forcing it to eject swarms of microRNA 29A. The primary target of this microRNA is a protein called SPARC. Normally, spark acts as a strict extracellular barrier that inhibits fat creation within the muscle. The miR29A swarm will intercept and suppress spark. Devoid of spark's protective inhibition, both the FAPs and the satellite cells abandon myogenesis. Instead of repairing muscle, they differentiate into fat cells. Age-related myosteatosis is a hijacking of the cellular niche. The muscle's own repair cells are pathologically reprogrammed to manufacture ectopic fat that destroys the tissue. This microscopic cellular hijacking scales up and directly resolves into the total limb dysfunction observed in geriatric patients. The density of this intramuscular adipose tissue correlates directly with measurable clinical deficits. Patients with heavily infiltrated muscle demonstrate noticeably lower gait speed and diminished knee extension strength. Standardized clinical assessments confirm this. In the Short Physical Performance Battery, or SPPB, patients with higher IMAT ratios predictably yield the lowest functional scores. Ectopic fat is an active, predictive driver of clinical frailty and severe fall risk. Standard clinical interventions for sarcopenia rely heavily on nutritional protocols and resistance training. Yet many patients fail to improve their physical function even when adhering to rigorous physical therapy. These side-by-side bar charts track post-exercise muscle quality. High levels of IMAT blunt the muscle's adaptive response. A patient with low IMAT shows a steep positive growth curve after training, while a patient with high IMAT shows a completely flat, suppressed response. Therapies must target the upstream signaling environment. Clinical approaches need to stop adipogenesis at the cellular level, rather than solely trying to treat the downstream atrophy. Extending our human health span requires treating sarcopenia as an infiltrative cellular disease, rather than focusing exclusively on total tissue volume.